everyone. I think at the outset, I really like to thank Annapurna and Shankara Cancer Center for giving me this opportunity to come here and share my journey and experience of how we created the Kolkata Gynaec Oncology Trials and Translational Research Group. Now, I really wanted to name it India Translational Research Group, but then it landed up being Indigo. And we thought there would be a conflict of interest with a major airliner, so nobody wanted that name Indigo, so I stuck with KolGO TRG. So anyway, I will go through a little bit of my journey because how we developed this group is a story in itself. So I will just go to the next slide. So you have heard about this, but what is more important is the bit on the left. So of course I qualified from the Medical College, Kolkata, I did a DGO, and then I did an MD in All India Institute of Medical Sciences. So the first topic that was given for me for my research was going to be looking into BCL and BACs in cervical cancer, the patients going to have radiation versus CCRT. That was the first time that CCRT had come in place. I'm talking about 2000. But for 1 year, the radiotherapy machine did not work in IRCH. So my professor, Nirja Bartla, changed my research topic to daily versus intermittent iron supplementation in pregnant women. So I learned about dose reduction, I learned about toxicity, I learned about GI toxicity with ferritin, and that was my first introduction to lab. And also some HPV work, of course with Nirja, you can't escape from HPV. And then I went to UK. The reason being, I realized after doing a randomized controlled trial from AIDS, when it came to publication, that I knew that we haven't followed this proper consort methodology. We haven't followed a proper trial design. So I was not happy. We published 3 papers, but I was not happy. So when I went to UK to have a formal training in gynae oncology, the first thing I did is to took a degree in clinical trials from London School of Hygiene. Then of course, doing your general training, and I always wanted to become a gynae oncologist. And then when I got into Gateshead, and that was the first and the biggest gynae oncology center in Europe then, and then they told me that before they will train me as a gynae oncologist or give me a knife in my hand, I was an obstetrician and gynecologist by that time, I need to know science. Because if I didn't know the subject, I will never know when to stop. So then that is my introduction to the lab. And I think I was lucky. I was just thrown into something. Suddenly at an age of 35, instead of holding knives, I was holding pipettes. First year didn't work, but then you know how perseverance takes place, and the surgeons, we really like results, so it makes you crazy. So anyway, that was the journey where I was introduced to a molecule and an assay, and the assay would become today's HRD assay. And the molecule which I was working, it was Newcastle University, NU1055, and that is today's rucaparib. So that I became a co-inventor of that drug suddenly. I didn't realize. So I came back to India, I was in Tata, and then I started getting milestone payments. I didn't know what they were. So I donated that meager milestone payment to the mighty Tata Trust so that they would give me a data manager so that I can start doing research in Kolkata. So that was the start, I would think, of the seed for the Kolkata Gynae Oncology Group. And then of course afterwards I got royalty for being the co-inventor of rucaparib. That was just after the COVID, and I didn't even think about, because my boss, who possibly will be the Nobel laureate of discovering the PARP, she donated everything. So I thought maybe I'll do the same. And then, that was the beginning, because I really want to acknowledge my guru, Nicola Curtin, at Newcastle University, to be able to give the credit to a PhD student, which is something I see many places, a rare commodity, to be acknowledging the student who does the work. So this is where I want to give this introduction, because this has created this group in a way. How do I move that? Okay. can move the slide and then you can maybe keep on doing what you're doing. So I'm going this way. Right. So then the birth of Kolkata Gynaec Oncology Research Group is again another story, because that time the Interlace trial was coming to India. You all know about Interlace. It has just been published. So Interlace is a gynae cancer intergroup study. That means you need to have a group in your country to be able to be a part of a group, which is a consortium. It's like a G20 consortium. And you have the NCRI, you have GOG, you have AGO, you have, all these groups. So there was no group from India. And they have been trying for 20 years to invade into Tata, to be able to AIMS. But AIMS and Tata do not want to work. Tata and Vellore doesn't want to work. So there was never a group from India. So I was introduced to that, sitting in the back bench, and I really felt I approached Tata Kolkata by that time. And because Tata Kolkata denied, that is when I went out of Tata to actually have a group formed between CNCI Kolkata and Sharaj Gupta. So if you see on the top, I got this the former members, Chittaranjan National Cancer and Sharaj Gupta. We started with Interlace. So that was the formation of the group, the first of our study. And then, you can see now we have many centers and many PIs from many parts of the country joining us in this consortium, from AIMS, from Shankara, from Adyar, so we are increasing the membership of the people, both scientists. If you see the map, we're very fortunate in Kolkata that within a 10-kilometer radius, we have ISAR, Bose Institute, Shaha Institute, Indian Association of Cultivation of Science, IICB, NIBMG, ISI. We were sitting in the gold mine in Calcutta. So it was very easy for me to actually get all the scientists and the clinicians on board to do translational proof of concept research. So that was our USP. So you can see the story. It started, of course, with the DST UK grant. That was an Indo-UK grant that was for the training purpose. Then we became a registered society with our official address. We became a GCIG full member in 2000. Then I got the royalty payment to set up our second office. We became a CIRO in 2022. We became an IGCS partnering organization, the first one from India, in 2023. Then we became a GCIG executive body member. I represent one of 6 in the world in this position now. And now we are an ICMR collaborating center for excellence. But we have a very strong partner, which is our patient group. I name it as Sharvajaya. It's Ma Durga. You can see looking after the river Ganges. And the bridge is the Howrah Bridge, but it's the bridge between the clinicians and the scientists. So that's how, and the flow of river is the flow of life. We have a partnering institute. So this is what we do. We have a clinical trials unit, we've got a translational unit, and we have a statistical unit. And I'm really very critical about setting up a novel trial design unit, because we can't be doing these big, fat, randomized controlled trials which are done by industry. We need innovative, adaptive designs, biomarker stratification, so that we can do our academic studies with a much less sample size and big economy. So translational proof of concept. So we have these 3 with our AIM, high quality academic studies. Can't show on the top, but it's because maybe we can move that down. But anyway, you can see the thing that made in India solution for cancer clinical trials and supporting other institutions too. Now here you can see, this is the GCIG group, G33 we call it. So we had all these groups from Europe. You can see AGO, the CGOG, Gynaec from France, Mango, Italy, NCRI Europe, you've got GOG in USA. In the Asia, we have Japan, we've got Singapore, we've got Korea. The only one from India is our group, so we're on the map. And this is what we do. We send 6-member delegation team twice a year representing India. It's like presenting in Olympics. We got our flag, the last one from the group, on the group. But here we are, one art, one family, one mission. And the mission is to do academic proof of concept, translational clinical research, right? These are the studies which we are participating from India, but now we are having a role reversal. We have made in India studies where we have global participation. So, why is it not moving now? Go back on the screen. It's got hang. So next, what I was going to do is to kind of talk about a little bit about the studies that we are doing right now, because that's where I see the scope for collaboration with Shankara. Let's do the smaller, maybe just do not the screenshot. Let's go back to the original thing. Yeah. So this is what we do. So this is where we are switched between, we are ICMR CCOE. On the one hand, we have the Gynaec Cancer Intergroup. On the other hand, we have the International Gynaec Cancer Society. And we are, really looking into trial methodology strategy, which is, I think I want to move this from the screen because I can't see. I don't know what to do. Can you hide this? Maybe. So we have better biology. We got better clinical trials using newer study design, patient-adapted endpoints, and I call it an RCT strategy, which is rationalizing and reducing the cost of running randomized controlled trials in low resource settings. So that is RCT approach of doing an RCT. So that's what we are doing. Morbidity and toxicity reduction is a real focus for all the studies which we do, improving quality of life. And this is what I am as the CCRN co-chair now, which is a cervical cancer research global network. So I'm the co-chair of that. We're using an EDI strategy in clinical trials, equity, diversity, and inclusivity. And these are the components which have emerged from India, which is being adapted in the GCIG strategic vision. Suddenly they have realized that they just can't do all these studies in wealthy countries. So they really need to reach out to the masses where the 70% of the cancer burden lies. And this is my role as an executive body member and the co-chair to really put up our problems, put up our voices, so that the solution, the trials which are running there, they reach to us and our trials reach to them as well, including the science. So that is a very big part, which is harmonization of biobanking, harmonization of clinical trial protocols, translational studies. So this is something which we have been doing. And the main other thing, I think that we are writing a lot of consensus guidance on clinical research. So we have an ovarian cancer consensus guidance, a cervical cancer consensus guidance, endometrial cancer consensus guidance, and these are our guidance on how to do research in these fields. Like, it's not clinical guidance, but research guidance. So we're contributing to those too. Okay, so we'll go back one. So maybe next slide. I think we just change it from there. Okay, so I don't want to go through this slide. It's getting in this thing. But this is something that's very important. I'm just going to give an example from ovarian cancer. Now, on the left side, if you follow the row or follow the column from top to bottom, this is what would happen in a life cycle of a woman with ovarian cancer. So they would have a good quality surgery, and they may have intraperitoneal chemotherapy during surgery. Then they would have a BRCA testing or HBOC. Then they would have an HRD testing. Then they will go on to PARP inhibitors or Avastin as a first line. Then they would have a recurrence, and you do treatment of recurrence. Then you have quality of life, morbidity, and survivorship. So the 6 months of the year when I'm in the UK, you see in a high resource setting, I don't even need to think about it. It just gets done automatically, that clinical process, right? It's all funded, right? But when you come to a situation where you don't have all of them, and everything in different combinations and patchy. And you have to remember, the survival of a woman is actually dependent on all of these happening correctly. So you can't do a bad surgery and give PARP and expect a survival. Neither you do a good surgery and not give PARP and you expect a survival. So if you are running a translational study, even to normalize your arm against which you are going to assess your overall survival of your intervention, you need this box followed properly. And this is where we have come, our KolGO TRG approach, filling up for solutions for all these boxes. And that is what I've been working for the last 10 years. All right, we didn't have good surgery. I knew that. I don't know about here, but when I stepped in Kolkata, 2014, we were not doing good surgery. 2 hours cytoreductive surgery. What is that? I take 2 hours to do just the pelvis. Most of the diseases in the upper abdomen, right? So the first thing was to start up an ESGO fellowship in Kolkata, in Tata, then the IGCS fellowship in CNCI, at least to train the people to do a proper surgery so there's no residual disease. Then HIPEC. You can't give HIPEC to everybody, it is toxic. So our strategy is biomarker-driven HIPEC, homologous recombination directed HIPEC. That's a clinical trial which I will start shortly. Then, genetic, BRCA testing, you don't have counselors. So we have started training nurses, nurse-led genetic counseling and awareness. And we got an ASCO IIG award for that and many other international awards. Then the HRD testing, I was the inventor of the functional HRD assay. And, for 50% of my samples went to Myriad for Adam Foundation Medicine for their validation. So the genomic assay is now $3,000, where my original assay is $50. So this is what I'm trying to develop as a made in India assay now with BIRAC and with CMI, and I'll show you that thing. And then PARP inhibitors, I'm a developer of a PARP inhibitor. My heart sank when I saw that none of our women over here cannot afford to take it. 10 years, 15 years ago, it was so costly, nobody would get it. So we started getting into an alternative dosing strategy, reduced dosing strategy. I'm going to talk about it. I don't have time. Then we have biodiversity in an arsenic endemic zone in Bengal. Arsenic is a competitive inhibitor of PARP so that you can have more toxicity. So we really need a strategy for that. Treatment of recurrence, quality of life, and then we have our survivorship. So this is a strategy for ovarian, but it would be the same strategy for cervix. It would be the same strategy for endometrium, working through the entire journey of the cancer and trials. So this is me. This is how I look like. 2008, in that time I didn't know, I went just to the lab and somehow something cracked and we came up with this, it was a worldwide press release through, BBC and all that stuff. Test selects 60% of women with ovarian cancer which will benefit from the SMART drug. So that test is today's HRD test and the SMART drug is today's rucaparib. So this is published, this is done before TCGA. So the first ever study in the world to show that 50% of ovarian cancers respond to PARP. So anyway, this is, we're going to talk about it later on, but this is my assay, the RAD51 assay, and ESMO has come up with a guidance that this is one of the academic assays which needs more work and is still valid. I'm not going to go through that, but I was trained as a surgeon after that. So the first, on the left-hand side, what I used to do the operation, cross the time bridge, set up my cultures in the lab. At that point of time, I didn't know which of them would be ovary, which would be endometrium, which would be metastatic breast, and all of them grown. I grown them all, and then I used to test this drug, which is PARP inhibitor. So what I found, that the ones which are HRD, irrespective of the biology, PARP will work. So that is the beginning of thinking of a basket clinical trial. It doesn't matter. If you have HRD, whether it's prostate, whether it's breast, whether it's ovarian, PARP will work. But the more important thing is, and this is where I don't like the data from Prima and the others, it is very clear. If you have homologous recombination competence, RAD51 is up, none of my culture plates responded to PARP. And I know that by heart because I have repeated those experiments thousands of times. And so when people say that in the 50% of the HR competent group, you're going to give PARP and get 3 months of benefit with 40,000 pounds and resistance, I resist. There's something very important as a surgeon I realized, that if you look into that cohort, it's only 50 patients, but biologically stratified. So we were very good surgeons in Gynaec. But if you see the rate of complete cytoreduction, in a chemosensitive HRD tumor, the surgeon could cut out 80% time properly. But if the tumor biology was bad, where the PARP does not work, where it is not platinum sensitive, where the survival is low, the surgeon was not also being able to cut out the tumor. So that was my introduction to tumor-stromal interaction. The cancer-associated fibroblast, the desmoplasia reaction, all of that, which goes hand in hand, the tumor-stromal interaction associated with a bad biology tumor. So you really need to do something different for these 50% tumors. So this has what I've been doing in the 2 continents. This is the time bridge. My hospital is on this side of the bridge on Gateshead, and the lab is on that side of the bridge, which is Newcastle. And then here, of course, this is the Harbour Bridge. So, where it doesn't matter where I have, but it's a clinician scientist bridge, and I'm working on the same things. What to do when you got HRD, and what to do if you don't have HRD. So that's what I have been doing for the last, and we built up in Tata. I have a strategy, got a survival strategy, the Prabhat Project Ovarian Translational. Prabhat happens to be my father's name, who died of cancer. That's why I'm doing this, but it fits with the name. And then you got the quality of life and economics. So all of these programs I build up similarly, not like one after the other, but parallel to do this work. And this is Prabhat. You can see everything is based on HRD. So HRD and surgical resistance, that is what I was talking about, why the surgeon cannot even cut the tumor. So that's the surgical resistance. HR and CSC, HR ROS modulation, HR and HRD, I would say hypothermia, model generation, a biomarker with Harvard, with a microRNA, with lamin top, epigenetics and all that stuff, and then trials. So these are all the Prabhat group of studies which had started since 2016, something or the other happening and all. This is the academic HRD assay, which I'm now working again, because it fits the ICMR and the DBT remit of biomarker or diagnostic assay development in academic institutions with a low cost of treatment. So this I will be doing it with VIRAC and others, but this is where the assay will become low cost, and hopefully we will come up with the next generation academic HRD assay. So these are all the partners that we're doing. What is called Prabhat in India is called TORCH in UK, T-side ovarian research. So we have Prabhat TORCH meetings. So we're doing this. I'm doing the same things across the both countries and both institutions. One is, again, you can't see the top, that the HRD and the surgical resistance. This is the first Prabhat 1 study. I have come up with a signature where I call it phenotypic HRD. So there are 3 markers, CA125 less than 500, which is a non-secretory tumor, right? They don't secrete. Then you have infiltrative phenotype. As a surgeon, I have been taking pictures all the time. I know which is expansile, what is infiltrative type. So infiltrative tumor type, less than CA125, 500, and if you can't remove the tumor altogether, so that's a triad which really, really predicts it's HR competent. Nowadays, even before surgery or during the surgery, I can tell it's HR competent and it matched. So that is your phenotypic HRD assay. We publish or we keep on publishing, and then we're validating. I mean, you can see the distinct patterns of an expansile and infiltrative type of tumor, and it matches beautifully. And then these are all the publications I have had. What to do with the other 50% where PARP does not work. So I started a combination of kinase inhibitors and PI3 kinase inhibitors and PARP. But ROS inhibitors with Chitramundal in IICB and PARP, all those sort of things. But do you know what happens? You use a checkpoint inhibitor, you block the cell going into the S phase, and you would see less RAD51, but that's not necessarily inhibition of HRD. So that's why the combination does not work well. But what worked is actually heat, hypothermia. And it's a very funny story, but I mean, I got a Wellcome Trust clinician scientist grant, which I couldn't take, got a DST, whatever, but I have been working on this for the last 10 years and coming up with a strategy that how heat will help in the PARP resistant or HR competent tumors. And a lot of this work we published in ACRD in a repair. I'm still working on it with the DST grant. And this is my hypothesis, that the HIPIC can be targeted because it will be working on the immune cells, it will work on the ECM matrix and the DDR. At 42 degrees, heat causes transcriptional downregulation of BRCA, and it resensitizes the tumor cells to olaparib or any other parib. And this is my trial. So that was the science. This is the trial called targeted HIPIC, right? So you don't need to give HIPIC to everybody, but actually, because the HRD, you've got PARP, so with the HR competent, I'm going to randomize into HIPIC and no HIPIC. And then again, you're going to look into the samples to look into what happens and all that stuff. So this is the framework of the samples, and I'm very happy for you to take part in as well. We're looking into the aside, I'm not going to go through all these things because we don't have time, but clearly you can see pre-heat and post-heat, there's a massive difference in the tumoral stroma. It gets loose and relaxed, and desmoplasia index goes down, matrisome index improves, there's a lot of things happen, cytokine profile, the exhausted T cells become rejuvenated, a lot of things. I had COVID and I was doing saline gargle, and I really understood what does a gargle do on an inflammatory surface. It mobilizes your immune cells into that way. And it's an evolutionary concept. When we were hit, in my younger days, the chun and haldi. Chun causes the heat and haldi causes the anti-inflammation. It's a very, very old concept of how you use heat to do a lot of things. And I think it's actually the immune axis rather than the DDR axis where the HIPIC may work. More and more I'm kind of thinking about that. But anyway, then this is our umbrella approach. So if it's HRD negative, we're going to do the trial HIPIC versus no HIPIC. What if they're HRD positive? Then you need PARP. Now we can't afford PARP. So that leads to my next study, which is intermittent PARP inhibitor in ovarian cancer. And this is again, 20 years of research showing that a single dose of rucaparib, this is from our scrapbook in our lab. Once the FDA approval was done, we looked back into our data and we found that a single dose of rucaparib shows a PARP inhibition more than 72 hours. Now, pharma will not do this trial, so we waited for academic fundings, CRUK DBT for a seed corn, then we got an ICMR grant now to do the study. We looked at not all the PARP inhibitors you can do this approach, only rucaparib because of its PARP trapping effect. And this is the preliminary study we did, and we have done the PK/PD at time points to show the pharmacodynamic inhibition that persists after the single dose. Patients are doing well. We have some patients very, very long response, and this is the pharmacodynamic assay, and no hematological toxicity, no grade 3 hematological toxicity. And now we're collecting all the samples through the trial, and hopefully we would be able to answer drug-induced anemia and the mechanisms, why it works, where it doesn't work, relationship with resistance, immune axis, and all these things. So this is the trial. Very happy for you to take part if you want. But this is the trial which is going to run in Brazil, Mexico, and many other countries. So this is the first Made in India study going global. So this is the translational aspect that we would do, smart design. Again, another study, Taxol-induced neuropathy. Again, a very common program. We started from the bench, looking into the neuroinflammatory markers, and then we're going to go to a clinical trial of low dose of Taxol biomarker selected, in a biomarker selected fashion, choosing the patients who are more susceptible to taxol-induced neuropathy and then give a low-dose regime. But in order to do that, is the last 4 slides, you really need to up your game for the primary treatment. Surgery, that's the first thing I did in Tata, build up the ESGO quality indicators. 2015, I did this work with all these components, database, reflective practice, putting imaging, protocol, MDT, all these things. And barriers, I have set up cytoreductive surgery programs in Tata, CNCI, in the UK, 2 centers now, but everybody has problems, everyone. I love this Anna Karenina, that the first line, if you remember, that all happy families look similar and all unhappy families are unhappy in their own way. This is cytoreductive program setting up in every center. When it's all working, they all look similar. It's not working, all have their unique problems, and you have to just go through those. So that's my implementation of setting up cytoreductive surgery programs. I call an ease model of implementation: ethical, easy, acceptable, affordable, sustainable, scalable, all these things. You need a biobank. Really, so our biobank is now an ISO certified biobank for gynae oncology, so that we can support international clinical trials. Otherwise people will not, give their samples to us, right? If you can't maintain the quality. We have patient involvement, a very strong patient participation in research. No research question passes our ethics until a patient is sitting in the design phase. And then this is ROC, regional ovarian cancer. So we have a platform to have telemedicine, central MDT, trial MDT, precision medicine MDT, survival support. So this is a concrete program to deliver with the trials. We're also working on cervix. So PARP is also a very good radiosensitizer. So there are many, I've done more work for the last 10 years on this. So in situations where you can't give platinum, 25% of our cases with nephrotoxicity, PARP is a brilliant radiosensitizer, and it's renoprotective. It increases the vascularity. So that's our next trial coming out. Data in the lab for 10 years. Now we're ready to go for the trial called PARP-RAD. Visarka, Annapurna will take part, hopefully with her idea, non-incentrated approaches. And then again, translational proof of concept for low-dose immuno and all that stuff. We are also developing biomarker-driven prevention studies. We're doing genetic counseling, collecting the samples, but we're really doing mutilating surgery, mastectomy, and what not, for people who are at risk but may not develop cancer. So we really need a biomarker to tell that you don't live in fear for the rest of your life. It's easy to say what to do, but it's also very important to say what not to do, not to live in fear. So if you have this, you may have BRCA genes, you may be a carrier, but you may not develop cancer. Or you may cancer at an age of 60. You don't need to have a mutilating, surgery at an age of 30. I think that is not bad. That is bad science. We have a biodiversity for arsenic, and so these are the type of programs we, as I say, it requires a lot of collaboration. In India, I have just been able to now get all of you on board. I have been struggling for the last 7-8 years. I'm very happy to see you all on board, as well as my international collaborations. So this is our journey of Kolkata Gynae Oncology Group, but it's like DPS, Delhi Public School, but doesn't sit in Delhi, right? So you don't need to be, threatened about the name. Just treat it as Kolkata's Rasgulla. It's for everybody. So thank you very much. Anyone wants to ask any questions?
Mic is not working.
Not working?
Working.
Working. Anyone wants to ask any questions to Dr. Asima?
That was a brilliant talk, Dr. Asima. Thank you so much.
course, have so many questions, but my one primary question to you is the HRD. I want your perspective on that it is not a weighted score for the BRCA-ness, the mutation of the germline BRCA, as well as the tumor alone if there is no germline mutation. And then there is the the loss of heterozygosity, the TAI and the LSTs. So, and they are not weighted. So, what is your opinion on how the score is developed? Where loss of heterozygosity could be a little more prevalent than the large scale transitions and telomere.
Yeah. So I think so that is one of the fallacies of if you read all the recent literature. Now so when I developed this assay, can you hear me?
Yes.
So one of the drawbacks was that I really needed cycling live cells to go into the sort of give something to create the DNA damage, see the gamma H2X, then they're cycling, then you see it's repairing, but the RAD51 is carrying the BRCA2 from cytoplasm to the nucleus is repairing. So that was the whole idea. But it required cycling cells. So then we really needed to think about some compromise where you can do from an FFPE, and unfortunately that is just represents a scarring, an old scarring with all these manifestations. So the studies which have used these myriad and these sort of genomic assays for their validation in the PARC trials, you will always see, like for example in the PRIMA study or the NOVA study, there are some HR competent who are responding to PARC, and then there are some HRD which are not responding to PARC. And this is exactly, and again, if you think that you have collected the block from the time of diagnosis of the surgery, you are giving the drug those days at a time of recurrence. By the time the tumor has gone reversion of BRCA mutations, there are so many other things. So functionally, that tumor is no more HRD. So I think these are the difficulties, but you have to have a compromise somewhere, which is the best fit, which is pragmatic and can be used. And I think we have to just live with it for the time being. But that is why all these innovations are coming, and I'm trying to develop that FFP-based combined IHC immunofluorescence or genomic, I would say, concoction, I say.
But RAD51 focus formation again is so dynamic. Do you think we could capture it with the FFP when we don't have a?
So that is why so the thing is that when the studies in the recap assay, they have always used chemo-treated samples because chemotherapy is inducing the DNA damage, and if you do it with geminin, so basically you have, or in my case H2X, so you only connect count the cells in the H2X positive ones or the geminin positive ones, where they are cycling. It kind of matches mostly because, as I say, in my assay it had got very, very high negative predictive value. That means if it showed RAD51 increase, none of them responded to PARC. The other way around is not that great. It's 80%, that, like you may say HRD, but, the PARC is not working all the time. But the other side is very, very important, that if you see the foci, none of them would respond to PARC. But in the FFP, coming back to the question, we're looking into preparing a media which would call the collection media, which will cause the DNA damage, and then you fix it. So we have to come up with some solution.
Functional assay that will complement the existing HRD,
or
do you
even
think
replace.